Well, good morning, everyone, and welcome to the annual Larry Greenberg Grand Rounds. Unfortunately, Dr. Greenberg has a competing family event, and so he's not going to be able to be with us today, but he wishes that he could be, and we're here to celebrate his legacy of work that he has done in medical education. For those of you who haven't had the opportunity to work with him, Dr. Greenberg has been on the faculty here for over 40 years, and he was the original director for the medical student education program and has really been a mentor to many of us here at Children's National as well as across the country in medical education. But I have the honor of introducing our speaker today, Dr. Fitzhugh Mullan, and Dr. Mullan is a professor of health policy at the Mullan School of Public Health, as well as professor of pediatrics at George Washington University School of Medicine. He graduated from Harvard and then the University of Chicago School of Medicine, completed pediatric residency, and then spent 23 years in service with the National Health Service, initially as a pediatrician, and then actually the director of the program. Before retiring once in 1996, he was the Assistant Surgeon General for the United States. He subsequently directed the Bureau of Health Professions, and he was the contributing editor for a journal called Health Affairs, and he started a new section called Narrative Medicine. He joined the faculty at GW part-time in 1997 and full-time in 2005. His research and policy interests have focused on U.S. and international workforce development in health professions, specifically in medical education, and expanding now to interprofessional education. He's the director of the Atlantic Philanthropies Funded Leaders for Health Equity Initiative, and he's the co-director of the GW Health Workforce Institute, as well as the primary investigator for the Robert Wood Johnson HRSA-funded Social Mission Metrics Study. He's also authored several books, one of which was in 1977 called White Coat, Clenched Fist, The Political Education of an American Physician, also Vital Signs in 1983, A Young Doctor's Struggle with Cancer, and Plagues in Politics, the story of the United States Public Health Service in 1989. He's the founding president of the National Coalition for Cancer Survivorship, founding chair of the Steve Global Health, and founding board chair of Beyond the Flexner Alliance. He's also has been inducted as a member of the National Academy of Medicine and the National Academy of Science. So it's with pleasure that I introduce Dr. Mullan.
Thank you, Mary. Appreciate the introduction. It's good to be back at Children's. I'm perhaps a truant professor of pediatrics. I'm sure you're all saying, well, I never saw him professing. I'm mostly at GW and was in active clinical practice at Unity Healthcare Cardozo up until about 2013 with lots of business here and superintending or proctoring residents from Children's during much of that time. So although I am truant, I'm a proud participant in the faculty of pediatrics at GW, including at Children's. And it gives me great pleasure to give this lecture. Larry Greenberg is a friend. For those of you who don't know him, he really, in my mind, represents education in pediatrics, but in medicine. And his point of view is, and I'm sure many of you have thought of this, see one, do one, teach one. And the seeing and doing, we go to medical school or residency and so forth and get a lot of our hands held. The teaching you're supposed to do because you teach, right? And there's all this tradition of doctors, teacher, et cetera. But the fact is none of us, very few of us get any conscious training where we devote attention to the art of teaching and the science of teaching. And Larry's been all about that, about being conscious, sentient, prescient, and committed to teaching. So it is a pleasure to be here celebrating that and celebrating Larry, and may you have a good time wherever you are with your family today. Thank you, Mara, and thank you, colleagues. I didn't realize it was Education Research Week, and it's an impressive array of speakers. I'm very glad, and this is a bit of an ad, that I do not have to go back-to-back with Camara Jones, because she would win. So for those of you who have any question about what to do in the noon hour today, come here to Camara. You will not leave unmoved or unenergized. She is terrific. So what I have the privilege of doing is spending a little bit of time talking about a voyage I've been on since medical school, really, but a voyage which is, I think in the last number of years, picked up steam, not my voyage in particular, but this question of social mission it started as medical, now it's really health professions education. And it is a pleasure to talk to you about it, because the core of what goes on, or the core of what I spend a lot of time thinking about, worrying about, working numbers on, is the issue of what goes on within a medical education, particularly in regard to what we now are calling social mission. And that really is the story itself. So the poor are getting poorer, but with the rich getting richer, it all averages out in the long run. Attitude which is perhaps emblematic of at least some of the leadership of our time. But I want to pause for a moment on two intellectual movements which you've all encountered, at least in name, and perhaps more so. The first is the notion of social determinants of health. And this is an early slide from Sir Michael Marmot, who really is the founder of the social determinants of health movement. This is from what was called the Whitehall I study, published in 1978, and it was looking at British civil servants, all people who had a job, all people who had health insurance, effectively health coverage, and how did they do? And he entered it, and I was with Sir Michael last week. He was at the Beyond Flexner Alliance conference, which I'll mention. He entered this quite naively, not at all sure what he was going to find. And what he found was a fairly substantial and really career-spawning or movement-spawning set of differences between folks of different levels. And your likelihood of premature death, your likelihood of incidence of cardiovascular disease, and a variety of other measurable biological phenomena was related to your level in the service. If you were in an administrative position, that would be a high executive, your prospects were far better than in a very graded stepwise fashion if you were down the scale with clerical and other drivers and the like being at the bottom. So something was going on here that didn't have to do with healthcare access, didn't have to do with being employed. It had to do with precursors you brought to the job, presumably. And these are the social determinants of health. And this is 1978, so he spent 30, 40 years since then pursuing those in all manner. The other concept is health disparities, a linked concept, but a different one in origin and in concept, and that is that prior to 2002, I believe, was a publication of the National Academy of Medicine report on disparities called unequal treatment. And prior to that time, there was lots of talk about blacks doing worse than whites, or certain populations not doing as well as others. And many of us, and there was a literature on it, but it was not universally agreed to or respected. That report really nailed it. And after that, no one could disagree with the notion that were frank, clear, traceable disparities in population outcomes. They weren't just black and white. They were men and women, they were old and young, there were a variety of things you could adjust. Look at two populations, they came out differently. Although the racial and economic factors were prominent, and however you looked. This is you've probably seen it, and you certainly recognize it as our subway system, and your longevity would appear to be related to where you live, and it is. But of course, it's not simply where you live, but what goes in to living in, say, Bethesda or Fairfax or wherever it might be, where you're living into your 80s, as opposed to living in the inner city, where you're just barely making it into your 70s. So something in the order of a 10-year disparity, and that's true across the country, in virtually any city, and some are more pronounced than this, in terms of the difference between folks living in one part of town versus another, the rich and poor, put simply. But what all goes into that, those are disparities. They are determined by social determinants of health, contributed to in any event. So disparities and social determinants are tools that as clinical scientists we have, and in fact the society has. So this kind of foggy notion of, well, maybe there's unfairness here somewhere, suddenly is in bold relief. We can measure it, we can track it, we can put it in various graphics like this. That's kind of a precursor to what I want to talk about, where we've gotten with social mission and medical education, health professional education. So the notion of what I'm calling vaguely social purpose has been there, and I'm sure whatever epoch you come from and however long your experience in the health professions is, you are aware, and probably, and I should put this caveat up front, this being a pediatric audience, I think the whole mindset is quite different. Certainly if you look at the spectrum of health providers or of specialties, those of us who go into pediatrics tend to be much more inclined towards this kind of thinking. And it's obvious, and I'm sure you've talked about this, or about some various settings, that when you're talking about children, it's very clear that their outcomes are not determined by themselves, the kids, but by the environment, starting with the parents. And so the whole notion that there is an environment that determines health, and that environment may not be as good as it might be, it may be unfairly constructed, and one child doesn't have the same chance as another. That's kind of part of the drinking water of pediatrics. So if this were a surgical audience, say, or another audience, it would be a harder sell. But as pediatricians, I think we can pat ourselves on the back as being broadly socially purposed from the get-go, because when you go into pediatrics, you kind of buy that notion, less so in other disciplines, where the notion of fault or specific accountability of an individual is much more easily interpreted as the governing factor, which isn't to say responsibility isn't a factor, but we're talking about what governs. And if you can say it's somebody's fault, well, then that's their problem, not your problem. You can move on. And this is the sort of, no, wait, let's think about what's governing the outcomes here. And pediatricians are much better attuned to thinking big, as we will do. So this notion of social purpose called humanitarianism. It's been minority health, a term that's not used as much these days, but was used a lot in the 70s and 80s as a kind of post-civil rights movement notion. Faith-based care, primary care, community-oriented primary care, community responsive medicine was a little movement led at one point, but capturing this notion of something more there. Social medicine, social accountability. Social mission is a term that we've come to use to capture that set of instincts or that set of activities. It's not itself terribly precise, but it does propose to capture the various instincts, programs, activities that have been extant under those other labels. So in 2010, or actually 2008 when we started, we decided we'd try to measure the outcomes of medical schools in regard to social mission, a term that was less well accepted then, I think, than it is today. But it was very intentionally to capture those kind of social purpose concepts. And how do you measure that? We came on three pretty straightforward measures. Let's look at graduates in terms of, first of all, let's look at them roughly 10 years out. Not what a student says he's going to do, or not what a resident selects in terms of specialty, but when they've done their residency, they've done their military service, their National Service Corps, whatever obligations, and they're in practice. They're grown up. You know, what are you doing? You're grown up. They're grown-ups. And what are they doing? Where are they? Who are they? By medical school. And we said there were 141 schools at the time we measured, which was graduates of 1999, 2001. So it was roughly 10 years prior to the time of our study. We looked at three issues. How many were in primary care? How many were in shortage areas, health profession shortage areas, HPSA, and how many were underrepresented minorities? Pretty simple, or fairly simple. You had to dig a little bit. And we ranked all the schools and developed a common ranking and index and ranked them all out and published in the Annals of Internal Medicine. The outcomes were at least a surprise, I think, to most everybody. So the top-ranked schools in the country were the 3 African-American focused schools, which at first, well, why would this be? Well, obviously, they all do very well in terms of underrepresented minorities, having between 70 and 80%, or between 70 and 90% underrepresented minorities. They do very well, as it happens, also in shortage area placements as well as primary care. But then you see a series of schools that are not household names. These are not the schools that are celebrated by the U.S. News and World Report. These are the right states of the world, et cetera, et cetera. And that was a little bit of a surprise at first. But when you ask who's doing social mission, who is producing doctors in substantial numbers to address these 3 areas of consensus national concern, diversity, distribution, and primary care, they're the schools that are doing it. And when you go to the bottom of the list, you see the marquee names. In fact, most of the well-known schools are in the bottom quartile of the rankings, with some exceptions. What you also see is a flip of both the U.S. News and World Report and the NIH funding levels. So by and large, there's an inverse correlation between NIH funding and social mission scores. There were 5 schools that were in the first quartile for both. So you can do both. They're all big state universities. University of Washington, University of Minnesota, University of Alabama, and 2 others. And these are largely schools in Washington was at that time 5 states. It was the only medical school. And as you may know, the WWAMI program, where they reach out to Alaska and the other states, they had a very powerful primary care rural health mission, as well as a heavy research mission. So you can do both, but it is not easily done in smaller schools, less so. But certainly, the schools that rank towards the bottom, the schools that populate generally the top of the U.S. News and World Report rankings, could do a great deal more. And a lot of takeaways, a lot of discussion from this, a lot of fighting about it. It was very controversial. AAMC disowned it immediately. And then the African-American schools went in and said, wait a minute, we come out at the top of a survey finding and you disown it. They said, well, no, we'll take that back. We just think medical schools are too complicated to be ranked. Now, you know, that's not untrue. It's not complicated, and ranking doesn't have its hazards. But everybody loves U.S. News and World Report. If you're on the top, you got the plaque in your dean's office, right? But then somebody comes along, you're not in the top, and you disown the study. That's so easy, I don't think. Anyway, there's been, I think, a good deal of thinking, rethinking, and this concept, happily, is more broad in the land. And one will note to researchers, being Research Week, if you want your research paid attention to, rank something. The press loves it. You know, they get a crisp story, and, you know, you can imagine here, Vanderbilt was dead last, Meharry was second. That's a heck of a story in Nashville. You know, in Washington, you had Howard up top, Georgetown at the bottom, GW in the middle. What's going on here? So I got a call from the Times. Well, you know, thinking about doing a story on this. What's the message here? And I hadn't actually looked at it. All 13 New York medical schools were in the bottom half, most in the bottom quartile. That is really, I don't know what you call it, a finding, but it's certainly something that gets your eyebrows. What's going on here? 13 schools, most schools in any state, and yet they're all packed at the bottom. Well, you may know about New York and GME. It's a huge GME factory. They get a quarter of all GME dollars. And the dynamics there, I mean, I began to unpack them because I know the field pretty well. But the story for the Times would have been, I emphasize would have been, why is New York doing so poorly? You may not like the mission, but the fact that everybody's at the bottom, what's going on here? So anyway, I gave that to the reporter, got really interested, and 48 hours later, she came back, no, we're not doing it, my editor's not interested. Well, New York's, you know, hospital, you know, mega institutions are very potent, and I expect that was not a popular story, so they didn't touch it. It's worth unpacking, and a lot to be said there. In any event, it was controversial. A lot of things could be said about it. Now, what is social mission? And I'm going to carry on this for a moment before I give you the rest of the history. The definition, the working definition that I kind of coined, but I think everybody's using this or some variant, is as we say here. I just want to emphasize, social mission health profession school is, and let me also pause for a moment. We started on medical education. That was a study was of medical education, and the notion was social mission medical education, which is clearly something I knew about and was focused on. And we live in this increasingly interprofessionalized world, or it's always been interprofessional, but greater focus on doing interprofessional training to go with the reality of the interprofessional workplace. And it took, my notion was if we can get medicine to change and value social mission, it will wash through the other health professions. It's a bit chauvinistic, medical chauvinistic. I think it's true, but nonetheless, the pushback for many was, no, if you're really going to do this, you need to talk about the full education system and the full workplace, and you ought to talk interprofessionally. So we made the conversion 3 years ago, really now, to talking interprofessionally, and nursing has come on very strong. Dentistry we're working on, it's nice as a physician to have dentistry out there, because any kind of social mission measure you want to make, they're worse, right? We may not be doing so well. We got folks who are over there. But there's been interest in dentistry, increasing interest in this issue. Social work is coming on strong. So it has become very much an interprofessional movement. So the social mission of a health profession school is the contribution of the school in the mission, programs, and performance of its graduates, in particular, that was our study, faculty and leadership, in enhancing health equity and addressing the health disparities of the society in which it exists. We worked on this a lot in terms of what exactly we were talking about. The notion of disparities, which are everywhere, are with us and will be with us, but are in every neighborhood or in the catchment area of every hospital, every school, are staring us in the face, and the question is, do we attend to them as an institution and as individuals in that educational institution? So that's kind of the core of it, not how much or what, but are you dealing with it, and is it an important issue in your mission, in your teaching programs, et cetera? Are you modeling engagement with it? And finally, the question of society in which it exists. Many schools in their formal definitions, and if you catch a leader at an odd moment and say, what's your mission? Oh, we're training doctors for, well, it's a global community, for the world. And that's fine. They may or may not be doing that, but that's a dodge in a sense, that they're not saying anything about the home court. Well, how are they define the home court? So we're now, the term of use is a community of commitment. Does an institution have a community of commitment? Does it say, you know, we're really going to take on Southeast DC and build clinics there and look to what we can do in terms of our research, what we can do in terms of our pipeline programs in an area? Does it take on, many, of course, have a definitional community, the state, they're state funded. Interestingly, though, some schools, say New Mexico, take that very seriously. And if you visit with, as I have several times, the school, you will find multiple dedicated programs reaching into the high schools, they now have an extension, model on the agricultural extension. They have a health extension worker, 5 or 7 of them stationed around the state, whose job is to be an ambassador from the medical school or the health sciences center to Farmington in northwestern New Mexico, and relate to student placements, relate to research projects, et cetera, et cetera. So a very serious engagement with the state. Others, say UCSF, are training doctors for the world. And while they have some programs that focus on urban medicine and the like, there's not really an institutional commitment to an area of a community commitment. So the notion of society, when it exists, is a little bit of a weasel word because it's designed to cover many different possibilities. But the social notion, there is a community called a society that has disparities, and are you engaging them or not? So the areas particularly, and this is always important, particularly for people who are less familiar with it, what are we talking about? And these are the sort of principal areas. You'll recognize at least 4 of them. Obviously, community engagement, which is a gold star activity for children's, obviously, diversity promotion, disparities reduction, and engagements with the social determinants of health. This cost-value concern is not well phrased, and what that has to do with is the responsible stewardship of resources. How do we teach our trainees to prescribe, not simply medications but tests? How do we, as stewards of the medical economy or large players in determining the medical economy, What do we model? What do we teach? We now know that there are, if you look institutionally using the Dartmouth Atlas and the work largely of Jack Wenberg, you can talk about hospital referral areas and you can look at the environment in which residents train. We did a paper, Candace Chen was the lead author, a children's graduate and an excellent researcher in this area, where we looked at the relationship between the cost of training in the institutions that people trained and their cost of practice in where they were practicing, which now can be done. And our hypothesis was that folks trained in a high-rent institution would have high-rent practices, and those trained in lower-rent institutions would have lower-cost practices. And in fact, that was the case over 15 years. And beyond 15 years, it seemed to wash out. This line of research is really important, particularly in education. So what we model in terms of how we practice as being stewards of resources does play out in terms of how people practice. And we know as a health system, we are incredibly inflated. We are spending way too much, ordering way too much, prescribing way too much. So these are factors that are part of social mission. We feel it's both good practice, and you won't have the spare change to do social mission if you're burning up everything in sight, feeding the clinical demands that are created by casual or careless stewardship. So we think that's one of the values within the combination. So following the paper, there was a lot of talk about, well, how do we move forward with this? And we have had a series of meetings, which I'll tell you about, under the label of Beyond Flexner. And the concept here, for those of you familiar with Flexner, you'll know that he was the leading reformer of medical education in the 20th century. A brilliant, hardworking, long-living gentleman. His famous report was 1910. He died, I believe, in 1955, something like that, and had a very productive life after that, although he's mostly known for his 1910 report, in which he went to every medical school in the U.S. and Canada at the behest of the Carnegie Foundation for the Advancement of Education, and came back with a scorecard that was miserable. He said most of medical education was rotten, and he used words like rotten, fetid, ignorant, etc. It's a fun read. It's easily gotten. Half of the book is these little vignettes of 3 or 4 pages about every medical school, which are fun. The other half is pretty turgid reading about the teaching of physiology in 1910, or teaching of microbiology. Not a good read. But amazingly, his findings and his recommendations happen, which there's many learned reports and many smart reports and opinions that get broadcast, nothing happens. And that's in the chemistry of history, which is always fun to look at in retrospect, but how it happens is hard to know. His came at the right time. People were receptive. He was not the only voice. The AMA was quite concerned about the state of medical education. And the fact was that prior to 1900, medical education was not much. We really didn't know much. And we taught stuff that we'd done for years, had been done. I mean, you know, leaching and purging and so forth was taught right through the 19th century. And it was the scientific revolution taking place in Europe, Pasteur and Koch and colleagues, starting in the 1870s and 80s, that really began to move medicine onto a more scientific basis. Hopkins was the first to recognize that, and as you probably know, they sent their early professors to Europe to study and bring that back. And that was beginning to percolate through, so that authorities, state health authorities, the AMA and others, looking at what medical education could be and what doctors could do, and seeing the mom and pop operations. Over half were proprietary storefront kind of operations. So they fell by the wayside. His prescription was that medicine should be taught in a research university. That has been misinterpreted over the years, explicitly and implicitly, as somehow medicine and research are synonymous. In this week of research emphasis, we can salute that, but that's not all that medicine is. In fact, that's not even a leading component. Research is a challenging topic, a very important topic, but to conflate research values and medical education values constantly is not good for a system, and we've done that for a century under the notion of Flexner. Now, we could unpack that, and I'm making a big charge here, but the skewing of the belief in what makes a good doctor to a kind of research set of notions has been extant in our system and has not been good for our system. Flexner was a progressive man for his epoch, if you follow his readings, but his epoch had a 10-year on what we would now call social issues. And this was the United States that had just resegregated. 1910, we're talking about post-Reconstruction. Ku Klux Klan was active. This is the United States that, after the war with Germany, World War I, was anti-social insurance. That was Bismarck. That was German. So there was a huge turn away from anything social, notwithstanding the challenge, economic and otherwise, of doing something about others. So we went ahead building a medical system that was attuned to and looked mostly at those ultimately who could pay, but towards the better heeled ranks of society. And that has come down to the present time. We really need to make a stand. It's not that Flexner's concepts were not good. He was a huge believer in teaching. He was a Greenberg before Greenberg was Greenberg. He wanted full-time faculty. He wanted the laboratory as a mandatory part, bringing in, let's do science. Let's do it in a scientific environment. It was quality assurance he was looking for. That was true in 1910. In 2010 or 2018, we can teach medicine online. You can sit in bed and learn medicine. Not recommending it, but the notion you've got to be in a research university is the only place you can study to be a health professional is simply passé. And the part of medical education, health profession education, to which Flexner devoted no attention, is this social mission, and that has been neglected for more than a century. So the notion is to move beyond Flexner, which is what this movement is all about. This was the first Beyond Flexner meeting, the University of Oklahoma School of Community Medicine in Tulsa, a unique institution in itself, and Macy Foundation, George Thibault is, I don't know if we can do, is right in the middle. Macy Foundation has been a big supporter of it. The second meeting was at the University of New Mexico in Albuquerque, 2015. Third meeting at Florida International University, a school devoted very much to a new school devoted to community engagement in the Dade County, South Florida area. At that meeting, we inaugurated the Macy Awards for Excellence in Social Mission. This was a team from Morehouse University that won the award that year as institutional. There's an individual program, institution, and lifetime achievement. Jack Geiger got the Lifetime Achievement Award this last time at the Florida International Conference. This was 2016. And then 2018, we just completed last week. Landry was there and others from Children's and GW. It was a terrific meeting, about 500 folks with those themes. This is Sir Michael Marmot, who did keynote the meeting and laying out both his historic identification of social determinants and where we stood now. He emphasized in our current global quandaries over budget and priorities that while people were talking social determinants, we really need to put the muscle in terms of investing in programs that do that. The Lifetime Achievement Award went to Loretta Ford. Does anybody know who Loretta Ford is? Recognize the name? You are looking at the world's first nurse practitioner. Lee Ford in 1965 at Denver Children's Hospital with Henry Silver, pediatrician, started the Pediatric Nurse Associate Program, which is the Jerusalem, the Mecca of the nurse practitioner movement. She's 97 years old, totally compassed, and clearly she went on to be the dean of the University of Rochester School of Nursing. Had been a force. Really fabulous to have Michael Marmot, who invented social determinants of health, and Lee Ford, who invented the nurse practitioner, at one podium in one day is pretty good. This is a group that met in 2016 to found the Beyond Flexner Alliance. We basically were a meeting going from time to time. The notion was, let's put this in play year-round. And this group met at a retreat center down in Virginia. Joe Greer of FIU is prominent in that. A number of nurses, Candace Chen, Candace Chen, a graduate of Children's, and group Don Weaver ran the National Service Corps for many years. A good group, and sort of laid down the running rules for that. So the core concepts of the Alliance are a culture of accountability in health professions education, to develop more public consciousness. I mean, we have a lot of things that celebrate, frankly, research. Do we have anything that celebrates on a national level social purpose, social mission, community engagement? I mean, yes, certain institutions have local kinds of things, but we don't have an Academy Awards. That's the Macy Awards program is an effort to do that, to recognize. We need to build public consciousness around the importance of this kind of activity by institutions, by individuals and departments and so forth. Future leaders, bringing people along, seeing careers that really feature prominent work as leaders, clinical, research. Research is very much a part of this. This is not to disown research. We need much more research in around social mission topics. Standards and metrics for social mission, I'll come back and talk about that. And workforce diversity is really core. Challenges is getting people seeing that this is an important part of their life as a learner, as a faculty member, as a policymaker, as a practicing clinician. The Beyond Flexner movement is focusing largely on the educational portion of the arc of a health professional's life, which obviously is a pre-service area of learning and training, and then roughly put a service area, presumably many more years, when you're actually practicing the profession that you learn. This unapologetically focuses on the pre-service area. Not that the service area isn't terribly important, and you will, when you will, and I have, is shopping these ideas around, have many people in leadership positions, particularly deans, say, not irrationally, I can train them, but I don't employ them, and I can give them the best precepts in the world, but let me tell you, when they get out there in the market, their behavior is going to be governed by who pays them what, and that is true, unfortunately. That is true. Let me not say it, but that's the reality of it. The work conditions of service will determine what people do in any walk of life. Now, two things. One thing is, that said, somebody who purports to be responsible for an educational institution has that person in their crosshairs for a substantial period of time, 4 years for medical school, add 3 or 4 more for residency, whatever the health profession is different. And the second thing is that you are selecting, not only training, but you are selecting folks with their values so that you, presumably, if you care about social mission, are both selecting and reinforcing social mission so that that's not simply a salesman going out who will sell cars for whichever car company gives them the most salary. These are folks with purpose, with ethics, with pride and competency, and presumably part of that is to withstand the lure of a marketplace, which, by the way, certainly in medicine, even the poorest recompense physician is not doing badly in this country, not true around the world. So I say yes, I realize the educational angle on this has its limits, but it's way better than anything else we have. And you all who are selecting and training and instilling values and providing role models need to take this social mission stuff seriously. So recruiting people in, quantitating it, which I'll say one more word about, being interprofessional. We have some interesting new models, and as you may be aware, we have now 2 in the last few years, health plans and medical schools that are collaborating. This year, Geisinger Health in Pennsylvania and the Commonwealth Medical College, and you, as yet or prior to that, unaffiliated medical schools, about 5, 6 years old, 5, 6 years of graduates, affiliated. So now it's the Geisinger Commonwealth Medical College, and they're doing a lot of their training in a very well-run, managed health system. And you have Kaiser Permanente opening a medical school next year, which will be a medical school based in a health system, not training for its system. It wants to train for its values, and those of its graduates who come back to work for Kaiser, they're fine with that. And you have, quietly in residency, you have something called the Teaching Health Center model. We have one here in DC at Unity, where you have a federal grant program that provides residency support not based on hospital affiliation. The GME dollars, as you're probably aware, which is substantial, 10 headed towards 11 billion per year. If you go nationally, and I realize Children's is not a prime recipient of that, but there now is Children's GME, which is a poor sister of the GME. Just to pause on that for a moment, Medicare GME is an entitlement, so it comes year in, year out based on the formulas that have been established. Children's Hospital GME is a legislative program, appropriated program. It's not an entitlement, so it has to go through the appropriations process every year and it gets bounced around. And it's based on a different set of formulas, but it provides money not as generously as the Medicare GME, but to unaffiliated children's, standalone children's hospitals. But instead, generically, the federal government provides in Medicare, it's about $110,000 per resident. So if you have a resident, you're getting $110,000 subsidy from the government before you pay anything for anyone. And AAMC and others argued, oh, that's way low, which is craziness, and we could spend a whole other lecture on that. But the fact is, GME money is very important, and the way we've established GME, tying it to the hospital, you only get the GME if the individual is in the hospital. If the individual rotates outside of the hospital to a community health center, to a private office, to a public health office, technically the hospital does not count that month in recouping from Medicare their GME entitlement. So it's that restricted. And here we're talking about moving education into the community, moving the mindset in the community. So to get around that, there now is Teaching Health Center GME. There are about 60 programs funded, and they emphasize very much, and they're principally in family medicine, but their number in pediatrics, internal medicine, and the idea is that your principal allegiance is to the community. The funds come that way, and the educational focus can be that. So it's a model, a variant model kind of thing we need to experiment with and explore. And finally, this notion of putting the social mission on par with teaching, service, and research. I mean, everybody will tell you, what does a teaching institution do? It's teaching, it's research, and it's service. I think social mission ought to be the fourth, that we have an opportunity to make health better, but the institutions that are most visible representatives of that, the teaching establishment of this country, needs to really take seriously, not only for the training, but for the signal that it sends, that we have an ability to make a fairer, better society by working on provision of health in ways that are more adventurous, more imaginative, and more even-handed than the way we've moved, or at least can be added to our armamentarium, ought to be in the front ranks of what institutions do. So just a quick word about social mission metrics, a study we have mid-course. This is our advisory committee. It's looking at social mission metrics. How do you measure a school's contribution or an institution's contribution based on what it does? So that calls you to say, okay, what is social mission? Okay, say community engagement. What does community engagement mean? What are the activities that enhance social mission that are part of community engagement, part of diversity, et cetera? So we worked with a kind of Delphi group, our panel. We're a couple of years into this. We have fielded to 65 institutions pilot surveys, and are refining the survey, shortening it. And we will, and this is funded by RWJ and HRSA. We'll be going into the field later this year with a national self-survey. We've now got a pretty good survey, and we've really wrestled with the question of what are social mission enhancing activities. The question then becomes, how do you use this? We are not an accrediting authority. We can't tell anybody they have to do it. We really don't have standing at all, except as fellow researchers, fellow people interested in social purpose. And we've found, particularly at schools where we have contact, great receptivity. And the schools, and many of them reported this exercise, which is not easily done. It takes, depending, an average of 4 hours, but the times have been 2 hours to 2 days or something. I mean, pretty variable. But you have to put together a team. Some of the information is in the front office and finance. Some of the information is in the GME or CME or education office, et cetera, et cetera. But the self-study, which is an important part of any accreditation, where an institution is asked to examine itself is a important exercise. It's very familiar, and we've worked with and talked to accrediting agencies in nursing, dentistry, and medicine, and there are 7 of them, including 2 in medicine, osteopathy, and allopathy. They are interested in this, and they're watching, and they all have in their accreditation process some social mission type questions, variable from discipline to discipline. But the important thing is that coming up with this, we have something which we can use to go to the field with and say, why don't you do this and see how your school is doing, think about what you might do better. We will get, and we've already started to establish a data bank. None of this is publicly reported, so it's not a ranking, so we're not ranking anybody. But we do want to benchmark things. We feed back to a school, you're in the top quartile for this and the bottom quartile for that. Give them a sense of where they stand. So if they want to pursue this, they've got something a little more concrete to stand on, and they can do it again in 3 years and see where they've gotten. So that is the study that's underway. We have domains, which are these broad areas, and then activities. That's how we've broken it down. I won't tarry on this. I just want to end at our Beyond Flexner conferences last week. It was during the celebration or recognition of the 50th anniversary of Martin Luther King's death in Atlanta. He did not in Atlanta, but he was clearly, his church was there at Morehouse. So a lot of references to and a lot of thinking back. And King is, of course, rich in quotes, but there are a couple that are really important, I think, for our work. One, which I find is a sort of inclusive one, we're caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly. So the social mission notion is to invite people to look up and around. We are part of a larger community of humans, many of whom are suffering. And yes, our teaching hospitals, our medical schools are aware of that. They wouldn't be in the business if we weren't. But if we think collectively about how we can make that better and fairer, it will be good for all. And finally, the arc of the moral universe is long, but it bends towards justice. In this day and age, that's hard to wake up every morning and remember as we watch the craziness of our national political scene. I do believe this is true. I've lived long enough to see the civil rights movement get to where it's gotten today, and it isn't where those of us who participated. I spent a period in Mississippi in 1965 where we might have hoped it would have gotten, but it's way different than it was in 1965 for those who weren't alive then. So I think we have moved the arc, along the arc in a better way, but a lot longer way to go. So thank you, and Larry, I hope you appreciated it.